I'm not a cardiologist, but I spend a lot of my time looking after patients who are currently having or have recently had acute myocardial ischemia. These may be medical patients or surgical patients, and some of those patients have cardiogenic shock. In these two tutorials, I'm going to introduce you to the diagnosis of acute myocardial ischemia, what causes it, and how it's treated. The first one just looks at what myocardial ischemia is. An introduction to critical care, presented by me, your host, Pat Nelligan. Heart attack, part 1. In critical care, we often see patients who have recently had a heart attack, an episode of acute myocardial ischemia, either a primary type 1 myocardial infarct or an episode of flow demand ischemia, that's known as type 2. Not infrequently, we receive patients into critical care following reperfusion therapy or cardiac arrest, and in particular, following cardiac surgery. Hence, it's important to know what causes myocardial ischemia, how it's diagnosed on the electrocardiogram. This tutorial is about acute ischemic episodes. The next tutorial looks at how it's treated. Mechanisms of myocardial ischemia. In this tutorial, I will discuss myocardial ischemia, what it is and why it happens, coronary thrombosis and the evolution of myocardial infarction, myocardial injury and the ECG, myocardial geography and the ECG, myocardial infarction, arteries and the ECG. Let's look at 3 clinical scenarios. Sean is 58 years old and he's presented to the emergency department with crushing chest pain. It's radiating up into his jaw and down into his left arm. He's cold, clammy and diaphoretic. On his electrocardiogram, his ECG, there is ST segment elevation. He also has a raised troponin. This is his ECG. Pause the video and have a look at it. Angela is 63 years old. She felt weak and unwell. She came into the emergency department and an ECG was performed and there was ST segment depression across the inferior leads of her ECG with an elevated troponin. Isabel is 76 years old and she is post-op major surgery in the ICU. The nurse notices new T-wave inversion on the monitor, and that revealed when a 12-lead ECG was performed, T-wave inversion across the so-called anterior leads. Her troponin is raised, her heart rate is 100 and her blood pressure is 110 over 65 millimeters of mercury. Each of these patients is manifesting some evidence of myocardial ischemia. Let's take a look at the mechanisms and why the ECG changes. Myocardial ischemia occurs where there is inadequate blood flow through the coronary arteries to satisfy metabolic demands. So this is a demand versus supply problem. Too much demand, too little supply. And it may be caused by obstructive flow through the coronary arteries or inadequate flow in the setting of higher demand. For example, in tachycardia, there may be reduced diastolic flow time. There may be reduced flow, in particular with reduced diastolic blood pressure. And this may also be problematic if the patient has a hypertrophic ventricle, so a thickened ventricle. And the key thing to understand about myocardial ischemia is left-sided coronary arterial blood flow occurs principally during diastole. This is a cartoon of the heart, and we're going to look at a little segment of the left ventricular wall for a minute or two. The cardiac muscle is known as the myocardium. The surface that abuts the ventricle is the endocardium, and the outside, where the coronary arteries are located, is the epicardium. Blood flows from the epicardium to the endocardium. So if that flow is marginal, then there is a risk zone that is adjacent to the ventricle. It's known as the subendocardial layer. In this example, there is reduced blood flow so that the subendocardium is hypoperfused, and this worsens along the length of the coronary artery, and this is known as subendocardial ischemia. Where there is left ventricular hypertrophy, even a modest fall in blood flow can result in subendocardial hypoperfusion. To summarize this, left ventricular blood flow requires an adequate diastolic blood pressure to ensure flow. That is because there is minimal flow during systole as the contracting myocardium forces blood out of the vessels. That's the opposite of what goes on in all other capillary beds in the body. Hypoperfusion may be associated with obstruction to flow, low diastolic blood pressure, or low diastolic time associated with tachycardia, or relatively low pressure in cardiac hypertrophy. The major cause of myocardial infarction, that is the death of myocytes, is coronary thrombosis, blockage of one or more main coronary arteries. Let's look at the mechanisms. As one ages, one develops coronary arterial disease, the development of thick fatty plaques on the inside of the wall of the arteries. These narrow the arteries, resulting in progressive reduction in blood flow. Myocardial infarction usually commences with plaque rupture, so one of these atheromatous plaques ruptures. That rough surface activates the clotting cascade and thrombus forms on the site of the ruptured plaque. Crucially, that thrombus may occlude the coronary artery, obliterating forward flow beyond that point, or it may partially occlude, reducing flow. In that situation, the result may be just poor flow and subendocardial ischemia. The non-occlusive thrombus may organize and increase plaque size, resulting in intermittent ischemia associated with exercise or stress. If there is chest pain, we call this angina pectoris. Unstable angina is usually associated with chest pain with ECG changes that are not provoked, for example, by exercise. Sometimes flow may also reduce as a consequence of vasoconstriction. Taken simply, if a myocardial infarct is associated with plaque rupture and clot formation, the morphology and severity of the injury is determined by whether flow has stopped. This results in an ST segment elevation myocardial infarct. If flow is just reduced with ischemic changes, this is known as a non-ST segment elevation myocardial infarct. Occlusion of coronary arteries that ultimately results in infarction can be easily identified in most cases on electrocardiography. This is a very simple cartoon of the anterior wall of the left ventricle. Blood flow is normal, and this is reflected by our normal ECG morphology in terms of P, Q, or S and T waves. We can now review what happens in acute myocardial ischemia. I'm going to draw in a cartoon of a coronary artery. In this situation, flow is normal and the myocardium is healthy. Now we have the appearance of an occlusive thrombus that results in low or no flow, and as a consequence, there is ischemia to the myocardium beyond this point. Let's see how this impacts the ECG. When there is an occlusive coronary arterial event, there is subendocardial ischemia. The R wave is normal or nearly normal, but the ST segments on the ECG elevate and the T wave peaks. This is a reversible process. There is ischemia but not infarction. Early intervention with thrombolysis or better coronary angioplasty with stenting restores blood flow and prevents cellular death. In the absence of acute coronary intervention, ischemia spreads to affect the full thickness of the ventricle, and there are three zones: infarction of the subendocardial area, injury of the middle, and ischemia of the extremities. There is cell death and imminent myonecrosis. On the ECG, the R waves lose their amplitude and the ST segment elevation becomes more marked. Eventually, full thickness or transmural infarction occurs. The degree of injury and the likelihood of survival is determined by which artery is obstructed, whether there is sufficient collateral flow to serve the ischemic penumbra, and whether or not reperfusion has taken place, either spontaneously or following coronary intervention. The ECG changes now. The R wave may disappear, ST segment elevation starts to flatten, deep Q waves form, and there is early T wave inversion. The patient is at really high risk for malignant arrhythmias at this stage. After 2 or 3 days, the infarct is complete. The ischemia and inflammatory activity have abated and fibrosis commences, resulting in scar tissue, reduced systolic and diastolic reserve manifest by reduced ejection fraction and reduced exercise capacitance. The patient, if they survive, are at high risk for congestive heart failure. The ECG manifests this with an absence of R waves and poor R wave progression across the ECG. A marked Q wave on the anterior or inferior leads and deep T wave inversion is apparent. Let's move on and look at myocardial geography and the ECG. From the perspective of diagnosing myocardial ischemia, the conventional strategy is to perform an ECG and detect what wall of the heart is undergoing ischemic injury. This is a cartoon of the heart. It's cross-sectioned through the ventricles, so there are no atria here. On the left side is the right ventricle, and on the right is the left ventricle. So we're looking at the heart as if looking face on to a patient's chest. Sitting at the back of the heart are the inferior and posterior walls, and ischemic damage is seen on the limb leads 2, 3, AVF, with lead 1 the location for posterior wall ischemia. Working our way around counterclockwise, we come to the septal wall, and this is reflected in leads V1 and V2. The major muscle mass of the left ventricle is the anterior wall, and the mid-chest leads V2 to V4 reflect electrical activity on this wall. The lateral wall is seen in leads 1, AVR and AVL, but lateral wall ischemia may extend around to the anterior wall, and that manifests in leads V3 to V6. Looking at a 12-lead ECG, leads 2, 3 and AVF reflect the inferior wall. You should also look for a lateral wall extension in lead 6 and posterior wall extension in lead 1. The anterior and septal regions can be viewed across the chest leads V1 to V5. Each one of the patients that I presented earlier in this tutorial is manifesting some evidence of myocardial ischemia. So let's take a look at the anatomy and the mechanisms. All coronary arteries arise from the aortic root just above the aortic valve. The right coronary artery originates in the right anterior sinus and travels along the right atrioventricular groove, and it branches into the posterior descending and marginal arteries. It supplies the right atrium and intraatrial septum, the right ventricle, the sinoatrial node, the atrioventricular node, the inferior surface of the left ventricle, and the posterior 1/3 of the intraventricular septum. The right marginal artery comes off the right coronary artery, and it supplies the right ventricular apex and parts of the right ventricle. Importantly, blood flows to the right ventricle continuously throughout the cardiac cycle, in systole and diastole, because it is a low pressure system. Right ventricular infarction is relatively rare. Inferior wall myocardial infarction is typically caused by blockage of the right coronary artery. The right coronary supplies blood to the inferior wall of the LV, as well as parts of the RV and the AV node. If there is a left dominant circulation, the left circumflex artery may supply the inferior wall. This is a classical inferior wall myocardial infarct. There is ST segment elevation in 2, 3 and AVF with some lateral wall extension in the V5 and V6 leads. There is also likely posterior wall extension. In most cases, this is consequent of right coronary artery occlusion, but not necessarily, so you must do an angiogram irrespective. There is a risk of rhythm disturbances and right ventricular infarction. What you need to look for if you suspect an inferior wall MI, ST segment elevation 2, 3 AVF with reciprocal changes in 1 AVL and possibly V1. Remembering the blockage of the right coronary also affects the right ventricle and AV node, so keep your eye out for rhythm disturbances. The left coronary artery, also known as the left mainstem, originates from the left aortic sinus just above the left cusp of the aortic valve. It travels between the pulmonary trunk and the left atrial appendage, after which it divides into its main branches, particularly the left anterior descending the LAD that runs along the anterior interventricular groove towards the apex and supplies the anterior wall of the left ventricle. It also supplies most of the interventricular septum. It usually gives off a left marginal arterial branch that supplies some parts of the left ventricle. Occlusion of the left mainstem or LAD results in an anterior wall myocardial infarction. And that is what our patient Sam is undergoing. You can see ST segment elevation across the chest leads with deep Q waves forming in V2 to V4. Anterior wall myocardial infarction is caused by blockage of the LAD, which is the major branch of the left coronary artery or the left mainstem. The LAD supplies blood to the anterior wall of the ventricle as well as the interventricular septum and the right bundle branch in the conducting system. Typically, you'll see ST segment elevation in V1 to V4. Because this arterial series supplies the bulk of the left ventricular myocardial muscle mass, occlusion without reperfusion or with stunning or hibernation may result in pump failure and cardiogenic shock. The left circumflex artery travels along the atrioventricular groove to the posterior aspect of the heart. It supplies the left atrium and the lateral and posterior walls of the left ventricle. Circumflex artery occlusion has no specific ECG pattern. ST segment elevation may be seen in the inferior or lateral leads. There may be depression seen in the V1 to V4 precordial leads, and in 1/3 there are no ST segment changes seen. Posterior wall myocardial infarction is usually caused by occlusion to the right coronary or circumflex artery. If it's associated with an inferior wall myocardial infarct, there is a significantly greater area of myocardial damage. This is a patient that I looked after recently, and you can see that there is ST segment elevation in the inferior leads. I want to draw your attention to lead 2. This shows the characteristic carousel sign. You can imagine a child sitting on the ST segment that's depressed, holding on to the T wave. It's diagnostic of posterior wall extension. What you are looking at is upside down ST segment elevation. And if we turn the ECG upside down, this is what you see. RV and posterior wall infarcts require careful viewing of the ECG and additional leads. If you suspect a right ventricular infarct, then it should prompt placement of right-sided leads, and right V4 is the best lead for detection. It is often associated with inferior wall infarct if present. For the posterior wall, as I've mentioned, look for ST segment depression in V1 and V2. Look for that carousel sign and turn the page back to front and upside down if you have a printed ECG. Posterior leads may also be helpful. Right ventricular myocardial infarct usually involves occlusion to the right coronary artery that supplies the free wall of the RV. It's associated with inferior wall infarct and, on occasion, posterior wall infarct. There is ST segment elevation in 2-3 and AVF plus ST segment elevation in right lead V4. It is strongly associated with hypotension and shock, and outcomes can be very bad in this setting. One final thought. You need to be very careful assigning the location of a myocardial infarct based on the understanding of anatomy that I have just gone through. This is a patient who I looked after recently. You can see that there is ST segment elevation in the inferior leads and V4 to V6. So on the surface, you might think that this is an inferior wall infarct with lateral wall extension. On angiography, the culprit artery was the left anterior descending artery. That artery underwent angioplasty and stenting. So at the end of the day, you can never know until angiography has been performed. Let's review this tutorial. In this tutorial, I discuss myocardial ischemia, what it is and why it happens, coronary thrombosis and the evolution of myocardial infarction, myocardial injury and the ECG, myocardial geography and the ECG, and myocardial infarction, the culprit arteries and the ECG. In the next tutorial, I'm going to discuss the current management of myocardial infarction. I'm going to discuss the diagnosis of myocardial infarction, the management of ST segment myocardial infarction, the management of non-ST segment elevation myocardial infarction, and myocardial infarction in the ICU and why it's different. I'll see you then, and I guarantee you'll learn something. So that was acute myocardial ischemia. In the next tutorial, we look at how it's managed in the 2020s. If you're enjoying the tutorials, please follow me at YouTube or at my blog ccmtutorials.org. I'll see you soon.